I'm Dr. David Reuben. I am the Archstone Professor at the David Geffen School of Medicine at UCLA. And today I'm going to speak to you about what is dementia. What we're going to cover is what is dementia and what is not. How do you make the diagnosis of dementia? What are the different causes of dementia? The natural history and complications of dementia, and how dementia is managed. So dementia is a disease that is a disease of aging, and very few people who are younger than 65 actually have dementia, but as people get older, they're much more likely to develop dementia until we get to the age of 85 and older, where roughly half of older people have dementia. This is a disease that affects everybody. Everybody who I come into contact with or treat or teach will have somebody who is affected, a loved one who's affected. It may be a mother, a father, a grandfather, an aunt, an uncle who has this disease. So everybody is affected by this disease. And a total of 5.4 million Americans have Alzheimer's disease. In fact, more than who have heart failure. Can you help me with this? So a definition of dementia is an acquired decline in memory and at least one other cognitive function. So patients who have learning impairments from early on or have developmental disabilities do not have dementia. They have to have a decline in memory. And the other cognitive functions are aphasia, and that's how we speak to each other. The second is apraxia, and that's performing motor functions, such as combing your hair, or the most common example we see is driving, difficulty in driving. Agnosia, and sometimes they'll not recognize where they are or familiar places, and at the end, at end-stage dementia, frequently they won't recognize people, or sometimes even their own family members. Executive function, this is planning, this is how we kind of organize our days, etc. And the other important thing about dementia, the diagnosis, is you have to have the memory problems and at least one of these others, and it has to affect daily life. So sometimes people will have some of these problems, but it doesn't get in the way and they don't have dementia. So there's some things that aren't dementia, and one of them is depression. So depression has some of the same symptoms. People will say that their concentration is impaired, they will become withdrawn or sad, they will have memory complaints saying they can't remember things, but in fact their orientation is intact. They kind of know who they are, they know where they are, they know what the situation is. Now I'm going to mention here kind of a little caveat that sometimes dementia will present, in other words, the earliest symptoms of dementia will be depression, and we'll talk about that in a few moments. Another thing that is not dementia is what we call mild cognitive impairment. And here, patients will have a prominent memory complaint, and when you test these people on a formal testing, they will actually have memory loss. But most of the time, other aspects of cognition that we talked about will still be intact. The other very important thing about mild cognitive impairment is that it doesn't affect their general functioning. So mild cognitive impairment is fairly recently recognized, but it's an important entity because it represents a transition state from normal aging to dementia. What I mean by this is that if you have mild cognitive impairment, each year your chances of going from mild cognitive impairment to dementia is about 10 to 15%. So that over a period of about 5 years, you have about a 50% chance of developing dementia. On the other hand, 50% don't develop dementia. So this is something that we don't establish a diagnosis of dementia, but we watch these people very carefully. Normal aging. Normal aging is not dementia, and here is when the patient is much more concerned about the memory loss than the family. And they can frequently describe the accurate details of the event. So for example, my wife asked me to go to the store last Tuesday, and she wanted me to buy bread, apples, and eggs. And my gosh, I could only remember the bread and the apples, and I forgot the eggs. Well, this person is functioning very, very well, even though they made a mistake. And this is normal aging. It happens to all of us. People with normal aging have intact memory for important events. They may have word-finding difficulties. We all have more of that as we get older. But the other important thing is that function is preserved with normal aging. So how do we make the diagnosis of dementia? The first step is a screening process. In other words, gives us a high index of suspicion that somebody has dementia. And we typically do that through a few different methods. One is what we call a 3-item recall. And that's what we do is ask people to remember 3 items. I always use the same one. I ask them to remember a ball, a flag, and a tree. I make sure that they have it, that they've really registered it, and then a few moments later, I'll ask them to recall those 3 items. This can be combined in something called the mini-cog, which is the same test, the 3-item recall, but in between giving the items and asking for the recall, a clock drawing test is inserted. There are many other examples of screening tests. One of the most common ones is something called the mini mental state examination, which takes about 5 to 10 minutes. But these screening tests, the important thing about these screening tests is that they don't establish a diagnosis. They just raise the index of suspicion. So for example, somebody can do very poorly on a screening test if they have other things wrong with them. If they don't speak English well, or if they have language problems because of a stroke, or they have poor education, they may not do well on some of these. So to establish the diagnosis, you really need to have a clinician's examination. And this could be a primary care physician, it could be a geriatric specialist, it could be a psychiatrist or a neurologist. But the examination needs to go through the components of memory, including short-term and remote memory, also test language, test executive functioning, and visual spatial functioning, as well as ability to motor functioning. Most of the time, a clinician can establish a diagnosis in not too much time. Occasionally, however, the diagnosis is still unclear. And when that's the case, we will frequently refer for what we call neuropsychological testing. And this is a formal process that goes through a number of these kinds of little small tests, but takes generally 2 to 3 hours, and it's done with a professional. And at the end of that, they can give an idea of whether, in fact, there is where the impairments are, where the problems are, and whether they're sufficient to meet the diagnosis of dementia. In addition, we do laboratory tests to exclude other medical contributors, things like thyroid disease, kidney disease, liver disease. Sometimes some vitamin deficiencies can cause things that look like dementia. Finally, most of the time we will do an imaging study that might be a CAT scan of the brain or an MRI of the brain, or sometimes a PET scan of the brain to determine whether there are other causes. So for example, if there's been a bleed in the brain or there could be a tumor in the brain, but these are rare. So Alzheimer's disease. We'll talk about Alzheimer's disease as it's the most common cause of dementia. And these are some factors that increase the risk of Alzheimer's disease. The first is being older. And as I mentioned at the very onset, is that the older you are, the more likely you are to develop dementia. Family history can be important, particularly if the Alzheimer's disease starts early. In other words, if it has early onset in the person's 50s or 60s, it's much more likely to be hereditary. There is a genetic profile called ApoE4, and that if you have this gene, you're more likely to develop Alzheimer's disease. And as I mentioned earlier, depression sometimes can be a very early symptom of Alzheimer's disease, particularly that kind of apathy and flat appearance. There are some factors that can reduce the risk. A different kind of genetic determination, ApoE2, actually reduces the risk. There's been some evidence in looking at longitudinal long-term studies to show that patients or people who have follow a Mediterranean-type diet that's high in fruits and vegetables, and those who do a lot more physical activity are at a lower risk of developing dementia. So I'm going to just show a little picture here. This is something, a schematic of what the cause of dementia, or at least one of the thoughts about the cause of dementia is that there's a protein called the Alzheimer's precursor protein, and there's a bit of it that gets cleaved out abnormally, which is the A-beta part, and that accumulates as plaque, basically, which is called beta amyloid. Next slide. And the accumulation of this beta amyloid can cause what we call neurofibrillary tangles, but most importantly is cell death, that these brain cells actually die. And as a result of either cell death or other kinds of toxicity, the cells stop talking to each other, the cells in the brain, because there's no neurotransmitter. You know, the neurotransmitter is basically the chemical that allows one cell to talk to another. And the major neurotransmitter we're talking about is something called acetylcholine. The other thing that can happen is the wrong transmitter can be in that area, talking from one brain cell to another brain cell. And glutamate is the one that's a wrong transmitter, and that causes further injury to cells. Now, the reason I mention this here, the acetylcholine and the glutamate, is when we talk about treatment of Alzheimer's disease, these are the targets that we're currently employing. So from a clinical perspective, Alzheimer's disease is associated with loss of memory, loss of language, visual spatial problems, loss of higher level functioning, what we call executive functioning, and apathy. So these are kind of the characteristic hallmarks of Alzheimer's disease. In 2011, the Alzheimer's Association, working with the National Institute on Aging, reclassified how we think about Alzheimer's disease and put it into 3 stages. The first stage is the earliest stage before people manifest any kinds of problems. And the thought here is that there are certain biological markers. These biological markers may be changes on a scan, like a PET scan, or they may be certain chemical changes in the spinal fluid that indicate that down the road somebody will develop Alzheimer's disease. So preclinical, they don't have Alzheimer's disease, it just says that down the road that they might develop it. The second stage is actually when you have some mild cognitive impairment, when something is wrong, but they don't meet the diagnosis of dementia because generally there's not problems with functioning. And the biomarkers might help us to determine which of those people with mild cognitive impairment actually do progress to Alzheimer's disease and which don't. Remember I said that only about 50% actually do progress. And then the third stage is actual Alzheimer's disease or other dementias, and here the biomarkers may help determine whether somebody actually has Alzheimer's disease or whether it's more likely to be something else. So the natural history of Alzheimer's disease is that people tend to progress about 3 to 4 points on that mini mental state examination. So that over a period, the mini mental state examination has 10 30 points to it, a period of about 10 years, is that virtually all of the memory is gone. The other aspects of Alzheimer's disease are what we call non-cognitive symptoms. In other words, these are things that don't relate specifically to memory, but they are issues with Alzheimer's disease. And the first is what we call psychotic symptoms. Psychotic symptoms are perceiving things that aren't there. They may be hallucinations, they may be delusions that occur in about 20%. Depressive symptoms occur in about 40%. And as I mentioned, depression may be a very early sign of Alzheimer's disease. And finally, most commonly, are agitation and aggression. People who might have been very friendly and very docile during their life may become agitated, may actually have become physically or verbally abusive, and this can occur up to 80% of patients. The survival of patients who have Alzheimer's disease is typically about 9 to 12 years. But the course can be very variable. I've seen patients who've lived 15, 16 years. Patients who have other kinds of dementia tend to be worse. And the survival tends to be worse because they tend to develop complications that are not related to Alzheimer's, to their dementia, but can be fatal, such as heart disease or strokes. So the management of this disease includes cholinesterase inhibitors. These are the medical management. And Memantine. We'll talk about that. So the first step is managing the disease, but probably more important is managing the patient. And when we talk about managing the patient, we talk about managing comorbidities. These are other diseases that patients may have, caregiver support, behavioral therapies, and then if needed, a pharmacological medication management of complications and advanced planning. So managing the disease. The first class of drugs are what we call cholinesterase inhibitors, and the common names for those, the trade names are Aricept, Razidine, Exelon, and these drugs have shown to be of some benefit in Alzheimer's disease, Lewy body dementia, vascular dementia, particularly if there's also Alzheimer's disease, and Parkinson's disease dementia. However, an important thing about the cholinesterase inhibitors in this class of drugs is that they do not prevent the progression of going from mild cognitive impairment to dementia. And this has been studied formally in a number of studies that these drugs do not prevent that. So they should not be started for patients with mild cognitive impairment. The way these drugs work is most often they slow the disease progression. And the way I like to explain it to people is that if you have a case of, if the patient has Alzheimer's disease and the slope of their decline is like this, that these drugs may slow the decline or change the slope. So instead of being rapid, it may be slower. About 10 to 25% of patients improve, and about 25% tend to get no benefit whatsoever. There's also some evidence that some of the behavioral symptoms, the agitation, the psychotic symptoms, may show some benefit. Sometimes, particularly in settings when patients have been hospitalized or physicians are concerned that some medicines may be causing problems and these drugs are stopped, there are some patients who decline rapidly. And those patients, we know that they need the drugs, so we restart them. However, there generally becomes a point in the disease when we stop these drugs because they're no longer providing any benefit. Memantine is a second type of drugs, and it actually works differently. The cholinesterase inhibitors that I just mentioned provide more of that neurotransmitter acetylcholine, so they help the brain cells talk to each other. Here, memantine prevents the bad kind of neurotransmitter, glutamate, from injuring other cells. And so this tends to slow the rate of functional and cognitive decline and improves behavioral symptoms. However, it is pretty much reserved for people who have severe Alzheimer's or other diseases, and the FDA has not licensed it for mild or moderate only disease. So occasionally we will combine a memantine and a cholinesterase inhibitors. There have been some better outcomes in some of the studies compared to using only one of them alone. But some of the more recent studies have cast doubt on whether the combination is more effective. So this is still a work in progress, but many times we will offer people the combination of these two classes of drugs in an attempt to try to control symptoms. So there's a lot of things that have been studied for Alzheimer's disease that don't work. They've had some hope for them, but they haven't really panned out. So these include the vitamins B6, B12, vitamin E, and folate have not been beneficial. There was a lot of excitement about ginkgo biloba a number of years ago, but in subsequent studies that has not been effective. Hormones such as testosterone and estrogen have not been beneficial. The drugs, statins, such as Lipitor and Pravastatin and many others, have not been shown to be beneficial, nor have an aspirin or other drugs that are similar, like Motrin, et cetera. There was some early promise of some hope with vaccines. That didn't work out. However, new generations of vaccines are being tested. So the second and probably most important component of managing dementia is to manage the patient. And the first thing I like to say to patients and their families is that this is a lifelong disease, that we do not cure this disease at this time. And you have to play the ball where it lies. And what I mean by this is if the disease is early, I always like to include the patients in the discussion. If the disease is late, we really need to rely on family members and caregivers. We try to aim for the highest level of independence that works for everyone. And what I mean by working for everyone is it has to work for the caregivers as well as the patient. Because if not, the patient caregivers get stressed out and some bad things can happen. The third thing is to manage hot button items, and driving is perhaps the hottest button of them all. In the state of California, physicians are required to report cases of dementia. It's a legal requirement, and so that we have to report everyone. It's important to know that doctors do not make the decision of whether somebody can drive or not. The DMV makes that decision. But once we report a patient, then the DMV will generally send a driver medical evaluation form to the doctor, who contributes more information about the patient's medical condition, and then the DMV decides whether to further evaluate or not. And typically the further evaluation is having a written examination, vision testing, and a driving test. However, if the dementia is severe, and sometimes if it's moderate, the DMV will just restrict the license or take it away. Managing other diseases is very important, because just because somebody has dementia doesn't mean they don't have other diseases. And finally, managing the symptoms of the dementia. So caregivers. Caregivers are the most important resource a patient with dementia has, much more important than their doctors. Unfortunately, about half of caregivers develop depression. This is very hard work, and as I mentioned, it's a long haul. The more knowledgeable and the more empowered a caregiver is, the better care the patient will receive. This is the patient's best ally. This is their advocate. Their caregiver resources are available through the Alzheimer's Association and other community resources. At UCLA, we offer support groups, and I can tell you more about those in the question, or you can go to our website. Now, the management of behavioral and psychological complications. The preferred way to manage these is without drugs and using behavioral approaches. These generally mean training the caregivers how to deal with things like wandering, how to deal with things like repetitive questions, how to deal with things like not eating or not being willing to be bathed. Occasionally, we need to use medications for people who are demented and have depression. The antidepressants can be used. For those who are having behavioral symptoms, agitations, hallucinations, those kind of symptoms, sometimes we need to use medicines that are called antipsychotic. And these are drugs that have trade names such as Risperdal and Seroquel, Zyprexa. There have been some studies that have shown that they're not very effective. There was a major clinical trial a few years ago that showed that these weren't much more effective than placebo. And they also have potential for side effects. However, that said, there are some patients who clearly benefit from these drugs. And a more recent study showed that patients who had behavioral symptoms who were on risperidone, when that drug was stopped, their symptoms got much worse. So in terms of using these medications, I think from a clinical perspective, to be very judicious, use only when needed, watch very closely for side effects. But some patients, it's meant the difference between being able to stay at home and having to go to a nursing home. I can remember clearly one of my patients who kept firing her caregivers because she became increasingly agitated, and with just a small dose of some of these medications was able to stay in her home for the rest of her life. Advanced planning. So this is about planning for the future. If the dementia is early or it's mild cognitive impairment, we try to involve the patient in the long-term decision making. These include deciding who's going to speak for the person when the person can't speak. Sometimes there are many family members. And also to begin financial planning and anticipating long-term needs. A patient may be diagnosed to this early in the course of it, and it may be 5, 6, 8, 10 years before they succumb to the disease eventually. There are a couple of milestones I always like to tell patients and their families, is that these are things that indicate that there's been a substantial amount of progression and maybe things are coming near the end. The first is becoming non-ambulatory. When patients stop walking, that's a very bad sign and a sign that the end is not too far. The other is when they stop eating. When patients stop eating, it's getting very close to the end. And people always ask questions, what can be done about this? And what we generally say is let them eat whatever they'd like to eat and whenever they like to eat it. However, people sometimes will ask questions about using tubes, feeding tubes that are inserted through the stomach, and those really have not been shown to be any benefit. And people who have advanced dementia, we do not recommend those or offer them. So there are some hopes on the horizon. There are various treatments and prevention strategies that are in the pipeline. We hear a lot about these on the news, whether it's inhaled insulin or something else that seem to have promise. Generally, these, when they make the news, they have been tested in mice or rodents, other rodents, and are still a far way off from being tested in humans or approved. They're aimed at different steps in the development of this disease, and it may be that the optimal management in terms of prevention or trying to stop progression of the disease may be more than one drug. My suspicion is there will be many false starts, things that show promise and don't pan out. But in the meantime, we need to take advantage of what is available. So I'm going to say briefly a little bit about the UCLA Alzheimer's and Dementia Care Program. This is a program that began in November 2011 with some philanthropic support from some of our patients who had been affected, their loved ones had been affected with dementia, and they wanted to do something for this. In 2012, the program was given a grant from Medicare to rapidly expand the program to serve 1,000 people. The program works with the primary care physicians to provide care for patients with dementia by conducting in-person needs assessments. In other words, there's a 90-minute in-person visit with a dementia care manager who is a nurse practitioner who really determines what the patient's individual needs are and what the patient and the family's resources are to meet those needs. And on the basis of that, an individualized dementia care plan is developed, and this care plan is submitted to the primary care physician for approval, and once approved or modified, the dementia care manager is responsible for implementing that with the family. The dementia care program provides access 24/7, 365 days a year. If there are ever any problems related to the dementia, that you're not left alone. But it does not take over the management of the patient. It works with the patient's primary care physician. So what do patients and families get? They get counseling and education, linkage to UCLA programs such as support groups, educational programs. If people are interested in new medications and therapies that have not been released, they can enroll in clinical trials. We also link people to community-based services. The dementia care manager is really like an air traffic controller saying, you know, this might be very helpful for you, or this program offered by the Alzheimer's Association might be helpful for you. And then the dementia care manager really becomes your friend for life, your partner in this. So there's ongoing follow-up as often as needed. Some of our dementia care managers have related instances where patients need to be called every couple of weeks, or their caregivers need to be called every couple of weeks just to touch base and answer questions. Usually the first follow-up visit is within 1 to 2 weeks. And the way to refer patients to this is that patients have to have a dementia diagnosis. It can be any type of dementia. They have to be UCLA patients. That's all we're doing at this point, and not in a nursing home. One of the goals of this program is to keep people at home and not have them go to a nursing home, so we're not focusing on the nursing home population at the present. They have to be referred by a physician. Remember, this is a program that helps the physician to provide care, and we need to have somebody who we can talk to adjust the medicines, to work with the patients. And we have an email address, dementia@mednet.ucla.edu, that you can, if you're interested in the program, want to learn more about it, you can find out. So in conclusion, dementia is an epidemic, particularly among the oldest old. Many diseases have symptoms of dementia but are not dementia. And clearly the most important components are the history taking and the mental status examination to establish the diagnosis. The diagnostic testing with blood tests and the imaging studies are generally confirmatory, but occasionally we get some surprises. Physicians can do a lot more for dementia patients than we could a decade ago. We know a lot more. We know how to use the medicines. We know how to refer better. Drugs to prevent disease progression and their complications are still limited. And the most essential parts are the behavioral management and caregiver support. At this point, I think potential therapies that are going to be released are still several years away. We still have a lot to learn. We're not quite there yet. So at this point, I'd like to open it up for questions. And there's a # UCLAMDChat. And the other thing I'd like to mention is the website, the dementia.uclahealth.org. this is just a wonderful website. It's got a terrific film about dementia and about this program. And at this point, I'd like to stop and answer questions. Oh my goodness, okay. Yeah. So here's one that says, my mom keeps asking for her father. Should I keep reminding her that he passed away last year? So this is a very common complication of dementia, is that the same kind of questions being asked over and over again, and typically they are related to this kind of a thing. And typically what we'll do is answer that question and then move on and try to distract people so they're actually thinking about something else. So yes, Dad passed away last year. Why don't we go take a walk? Why don't we have lunch? Why don't we watch television? I watched my aunt and now mother go through Alzheimer's disease. How do I prevent this from happening to me? I wish I had a definitive answer for that. I don't. The best evidence at this point is really pretty general types of things. One is the Mediterranean diet has been shown to have some benefits. And the other, and I think it may be even more important, is physical activity and exercise. There are some studies that are going on that are looking at prevention of family members going on to having dementia. And a place to if you go onto the website that I just mentioned, they can tell you about the Easton Center where some of these studies may be being conducted. So is there a way to predict my mother's decline so that I can plan to take off time from work? So the answer is there's no really good predictors about who will develop complications and when they will develop complications. Typically, the onset of these tends to be slow. However, sometimes we can get surprised, and they're pretty precipitous. So I think one of the things, the approach to this is saying, what are the contingency plans? What if something happens, and saying not to plan that it might be 2 years from now, is if it happens at any time, what would the contingency plans be? So in combination is what is the course of the disease. So the course of the disease is very individual. It's very individual. I've had patients who have had very rapid decline over a period of 2 to 3 years. Other patients who've had 8 to 10 years with this disease, and some patients who have very stable levels of functioning and then have a precipitous decline at the end. My father previously adored his grandchildren. Now he seems bothered when they visit. Should I continue to foster these relations and have them visit? So this is an interesting question, is when does the kid start irritating someone? And all of us have a certain amount of patience for children. And what happens frequently with a disease like Alzheimer's disease is a lot of those kind of censoring functions that we have, or the kinds of things that keep us steady and even, tend to go away. And what I would suggest in this kind of a situation is shorter visits, so the kids aren't there that long, so you don't get that opportunity to kind of wear out the welcome, if you might have it. So I don't think it would keep them necessarily away, but I wouldn't try to force the issue and say, geez, this is something that somebody really enjoyed before. They may not enjoy that same kind of dose of the children any longer. But that does bring up an interesting point, is in terms of things that people enjoy. So for example, a lot of times people will enjoy music or nature types of things. And these are really good ways in which to help people who might have agitation or other kinds of problems get over them. In other words, how to cope with them. So I remember somebody who was very agitated, who had been a former opera singer. And the way they would calm him down was actually play opera music for him, and he used to sing along with it. So what complications of Alzheimer's can prove fatal? So typically what happens with Alzheimer's disease, and this is kind of a prognostic thing in terms of the course of the disease, is that in very advanced Alzheimer's disease there are some complications that are common and can be fatal. One of them is falls. And I think I mentioned earlier that one of the telltales that things are getting closer to the end is when people become immobile and can't walk. Similarly, simultaneously as they're having trouble walking, frequently they'll have problems with their balance, and they can fall and have hip fractures. This is very common. It even happens in hospital settings where somebody who has Alzheimer's or another dementia gets up, they think they're at home, they want to go to the bathroom, and they can actually fall in the hospital. The other big one is are pneumonias. So what typically happens is the swallowing mechanism in advanced dementia doesn't work so well, so that foods that we eat, instead of going down the food pipe, will go down the windpipe. And so what will typically happen is people will have recurrent pneumonias. And that's another sign that things are not going well, and that's a way in which patients with Alzheimer's disease typically will pass away. Can a person with Alzheimer's disease travel with their family? So this is a really terrific question, and it kind of depends upon where people are in their disease. Early on in the disease, it seems to do, people seem to do pretty well with this. As the disease gets more progressive, the change in location, the change of venues, the loss of the daily cues can actually be much more upsetting. We've had a number of examples where somebody would go to visit their children in a distant place for the holidays, and they get there, they're very confused, very uncomfortable. So at some point in the disease, there tends to be a time when travel can be very hazardous, mostly because it precipitates more confusion. Is it normal for someone with Alzheimer's disease to have a complete change in personality? There's really nothing normal in Alzheimer's disease. It's what can happen and what can't happen. And this certainly can happen. I remember dealing with a daughter of a patient and who had Alzheimer's disease, and saying, you know, one of the things about your mom's disease is that she's never been angry. She's never been agitated. She's been just so sweet. And the patient's daughter started crying. I said, what's the matter? She said, my mother was never sweet. She was never a sweet person. And this is just so different for her. So yeah, we do sometimes see these personality changes. Every time I try to correct my husband who has Alzheimer's disease, he becomes angry and agitated. Should I let him keep talking even if he is wrong? So one of the things we have to recognize with patients who have Alzheimer's disease, particularly if they're advanced, is that they don't reason well. They don't reason well with you. You can't convince them that they're either right or wrong. And so generally in these kind of situations, it doesn't really help to try to talk them into a different point of view or to correct them. It's probably better off to just say, okay, let's move on to talk about something else. You're right. Let's move on to something else. What kind of doctor should a patient with Alzheimer's disease see? What specialty? So the there are many kinds of physicians who can care for patients with Alzheimer's disease. I'm a geriatrician by training and practice. This is pretty much, I would say, a lot of my bread and butter. Probably about 40% of my patients have Alzheimer's disease, and it's something I feel very comfortable with. But a good general internist, a good family physician, many of these doctors can do a good job. Neurologists, some psychiatrists who specialize in this area. The Alzheimer's and Dementia Care Program that we're doing at UCLA is a step in the direction to help all physicians be able to better care for that, so that patients can remain with their regular doctor who's cared for them so many years, and this is just to help augment that care of this specific disease. Can coconut oil cure Alzheimer's disease? Well, if it could, I'd be taking it. But no, there have been some very, very preliminary studies looking at coconut oil. Most of the time we hear stuff on the news, it's really, it's news, but it may not be the final answer. And I would suggest, if there are some things that you hear about, ask your physician about that. Most physicians, if they haven't kept up with the news and heard about it, they can investigate kind of where this is. But most of the time, these things that appear on the news are really related to things that might be promising in 5 to 10 years. But I wouldn't really invest in coconut oil at this point. How does Alzheimer's disease affect the body? One way it affects it is that, in fact, these praxias that I talked about very early on, the kinds of things that you used to be able to do for yourself, combing your hair, driving, dressing, bathing, those kinds of things that you can't do, particularly later in the disease. And that's something that are manifestations, physical manifestations of the disease. Well, I think we're going to bring this to a close, and I want to thank everybody for spending time. Please, if there's other questions, dementia.uclahealth.org is a terrific resource for this, and my hat's off to everybody who is dealing with this disease. You are the true heroes of America. So thank you very much.